We took the DOLA clip out on that side. That's where we're going to readapt the new deal. There's our locator attachment part, and there's our torque wrench with the looks bent, and locator housing. And there is the locator bar attachment, which is going to go onto the bar. Okay, so we put this up in the oven for about 15 minutes just to heat all this up. Then you lower it, and you solder it immediately. Make sure you don't get a cold solder joint because all this is preheated. So here we are, soldered together, all polished up. Then we're going to go readapt this to that inside of her denture. None of this is being done in the mouth. I'm just going to snap this into here, snap that into there, and then make sure I have enough room here. Put my locator housing on here, flow some acrylic there, and just seat the bar in there and let it set up. And so that's what you see here. There's a quick set acrylic, housings inside of there. There's our solder joint. There's the original bar back here. And the only thing I can say about this is I didn't charge her enough because this is a lot of work. But it saved the case. I mean, it just saved the thing. I didn't want to make this over again, and neither did she. Here's the final. Here's the case in the mouth. I think that's a mirror image of it. But you can see there's where our solder joint is right there. So, and there's the final deal seated on that side. Her existing upper. And look, she's just excited as hell to have the security. You notice that her palate's covered, so it wasn't about having a palateless prosthesis. But she just thinks this is the greatest thing that ever happened to her because she's not worried about what can happen to patients. I have a guy who's a basketball referee. He's got an upper denture. He goes, foul! Denture takes off across the floor. Another patient sends me a postcard. Her name is Carolyn French. Sends me a postcard of her and her sister Maxine going down the Colorado River, and she said, Dr. Smith, I would never have done this in a million years if I didn't have implants. You know, we don't think like that. You don't think about that. You're so worried about, denture goes into water, into the trip. My office manager, Debbie, Jimmy knew her from years ago. Her and Chuck, her husband, ex-husband, go on a vacation. They're in Florida. She don't know he has an upper denture. They've been married like 8 years. She didn't know he had an upper denture. A wave hits him in the back of the head, in the ocean. I mean, he had to FedEx his old, we had to break in his house, go get his old denture, from wherever it was, and FedEx it to him. This guy was so embarrassed, man. He was really embarrassed. And so those are the kind of things that you don't think about. You think about function and being able to chew an apple and all that other kind of stuff. But there are other aspects of this that we don't think about because we're not a dentulous, And so, she just thinks this is the most wonderful thing in the world. However, I'm going to say this. There's all this talk about who should be doing implants. Should the general dentist be doing the implant? Should it be the periodontist? Should it be the oral surgeon? I'm going to tell you, I don't really care who does them. I think, though, that on the level that you intend to become involved, you need to just realize there's a lot more to it than it first. It's kind of like Pandora's box. You open up one box, and then there's 2 more doors, then there's 4 more doors, and it's like it's a never-ending learning experience. And then we still have to go back to managing occlusion, and we still have to go to oral hygiene, and we still have to go back to all the basics, aesthetics especially. And so it's a discipline that I find it's like a 10-legged monster. It's hard to wrestle. Stuff is always coming in out of left field. Well, this guy comes to see me, and his dentist is a guy that went to one of our courses. And the dentist did this before my course. Not that it would have mattered, but he took it before my course, and some guy flies in and says, hey, you pay me this, and I'm going to help you do 20 implants in your office. And so this guy does a few cases. Now he's raring to go, so he does this. And I'm not trying to throw him under the bus. It's just I feel bad for this patient because this is what he's got going on the bottom. So he smokes. He's got poor oral hygiene. So we're going to go ahead and do some implants. So this tooth's abscessed. These two are touching each other. There's vertical loss here. These things are sticking way out. I mean, it's just it's a mess. And so that's a problem. That's a problem. This is way off angle. That's a problem. That's a huge problem. That's a huge problem. So the treatment plan is we got to take them all out. And if you quit smoking, then I think you can think about having some implant done. And I never saw him again. But this guy was not owning it. He started talking about health food and minerals and all that crap. It's like, you know what? You're going to die from cardiac disease or cancer because you smoke. I mean, forget about the minerals and all that stuff. Here's another case. This lady had an implant fail here. They went and put another one over here. This is completely lost integration. There's no occlusion over here. So looking up close, you see bad peri-implantitis infection here. That was the whole thing about HA. Boy, it worked great at first. But boy, if bacteria got on that coating, particularly in smokers, all hell would break loose, and you get this lateral blowout. You know, and we were doing a lot of calcific implants because the school was really behind it a lot back in the old days. And I remember opening up a journal of the California Dental Association, and I started seeing these pictures, and I said, you know, I've seen a couple of cases like that in my practice. And, you know, fast forward to today, nobody does HA-coated implants anymore. So it was a great idea on the surface. It's just that it left the implants vulnerable to problems later on. So we get this deal in. This is no attached tissue down here, no bone down there. This is crap. You know, I mean, everything's just falling apart. So basically took this out, bone grafted it, added some other implants, and also used, I think we used some of the originals. No, I guess maybe not. No, I guess we used these two. We kept those two. But all this had to go. And this is just the final case. These are not custom abutments. These are all stock. Now I would use customs because it just works so much better. And this is just the final case after it's been restored. This is what you came in with. This is our old Calcitech screw hole technology stuff. This is just so much nicer. She's happy as a clam. Already went through all that. So we have different kinds of broken systems. We have from healthy all the way to toast. Something's broken. This is for dentists. Something is broken. We know it's broken. We can fix it right away, and we'll learn from it. This is experience. It's broken. We know it's broken. We fixed it. Don't worry, but we learned nothing. It'll break again. I'm just doing my damn job. So that's part of dentistry. It's kind of like those people that come in with recurrent decay problems, and we're just patching stuff up. Next thing, it's broken. We know it's broken. We don't think we can afford to fix it. It's broken, but we don't know it's broken. It's not broken. It is, but we're not willing to admit it. We have a lot of that going on. It's broken. We may or may not know it's broken, but mostly we don't care enough to try and fix it, to learn how we could fix it better or even accept help from people who care. And so we can all fit into all of these categories sometimes because people have a way of creating what I like to call compassion fatigue. I mean, they come in just to wear our ass out. It's unbelievable. And the busier I get, the worse it is. So you're getting busier, and then you're getting older at the same time, and it's like it's a perfect storm. But this thing right here, it's broken. We may or may not know it's broken, but mostly we don't care enough to try and fix it, to learn how we can fix it better, or even accept help from people who care. This is what we got to get, is we've got to get information from other folks, you know, and I've had a few original thoughts in my whole life, not that many. You know, it's because of Jimmy Iverstein that I'm set up real well financially, because I started hanging around with him and some other guys a long time ago on an island called Giles Island. These guys are talking about, you got to save 10%, you got to do this, you got to get out of debt, it's like, I never heard of this shit in my life, you know. And the older I get, the dumber I realize I am. Now I'm at the point where I don't trust any of my own thoughts. You know, it's like I second guess everything I do. So when a patient comes in with dental problems, they'll say, what do you think? It's like, I don't even want you to know what I think, because my first diagnosis is always wrong. So I gotta be in my office or at home when nobody's around bugging me, so I can think this thing through. And I want to look at it from this light, from this light. Sometimes I'll put a case on the shelf and snap on smile. You know, or something comes up and it's like, yeah, that's a perfect solution for this situation that I can't figure out. So we already talked about peri-implantitis. If you drive through Maurice, Louisiana, there's a guy, I forgot his name, but he's a guy that's going to give you a ticket. Port Barre, Maurice, Raceland, those are the places where if you drive too fast, you're going to get pulled over. Well, this guy sits in his car and smokes 3 or 4 packs of cigarettes a day. This is a nice-looking case, and he comes in one day, and take a look at that. I mean, it's a perfect storm. He doesn't clean it. He smokes. It's a disaster. So here's the salvage job. You know, we put some minis in there just to try and buy some more time. But look at all of this. You know, this is like, I don't know, Beijing, China, full of bacteria. and these guys are all, and that's just my theory, is that if somebody's got active, it's not just mine, if somebody's got active periodontal disease and you put implants over here, you're going to have trouble with those implants in a lot of cases because we got too many bugs growing in the neighborhood. So went back later, added some more of these. We wound up doing this, and that ain't the end of the story. Look, one of them's missing already. All right? And so we got all this going on. He's starting to break down up here. And here's the deal. No attached tissue. Plaque everywhere. This might look good on the surface, but this is what's going on underneath. Okay? So I don't pretend to think that we're going to grow all that bone back and that we're not going to get back what was there before, but all I'm doing is just trying to slow the fire down. And I've told them, this ain't going to cure nothing, but you got active infection up there. We need to clean all that out and throw some stuff in there and, pray to the patron saint of implants, I guess. This is all cleaned off. We were using a micro-etcher with glycine in it. Now I'm using that, and I'm also using a titanium brush. We're going to use tetracycline application for 3 minutes. Come back and polish these necks up real good, and then come back and add fusion bone drying to freeze-dried bone, PRF over that, close it up. We buy a little bit of time. There's a PRF right there. But is that going to cure it? I doubt it. I really do. Because the guy smokes 3 packs a day. He's not going to hear worth a damn. I don't even know why we did this. Good slides. Any questions?
I have a question.
Yes.
Would you ever have somebody sign a release on something like, we're going to do this hero dentistry, and have no idea it's going to work?
I tell them that kind of stuff. I'm just not real good at following all the rules.
I'm not even.
You know what I mean?
It's a lot of help to give me, and I appreciate that.
Yeah.
We've all done that.
Right.
But I mean, in this day and age, you think we could.
It probably is a good idea. It's a real good idea. I mean, there's no doubt about it. All my communication is verbal. It's like, hey, look, we had a discussion about smoking, and we documented the chart, and look, you're not going to quit smoking. I know that. You know that. We just got to put out these fires. It's not going to last, but, if you're willing to go through it, I'm not charging that much, so I'm getting killed on this. It's a dilemma. It really is a dilemma. And really, the best thing for him would have been if he just had up and lower complete dentures from day one. A lot of times you don't really discover these problems until you're married. You know what I mean? Anybody been married more than once? I haven't yet, but what I'm saying is, it'd be too expensive. But what I'm saying is, a lot of times you don't know the patient until it's a little late, and then that's a matter of just trying to, use your communication skills and empathy and all that stuff, and knowing the whole time, I want to kill him. I want to kill him. And the way he's going to die before those implants fall out. I mean, he's just that. His skin is great. You know what I mean? He's one of those guys, when he walks in the room, he's a smoker. You don't even have to ask him. So we went to complications. I'm going to show you a case. What were you going to say? What? The membrane does resorb.
And the tags do.
They do, but I've seen them kind of still hanging around, but it's not an issue. So it's a neat system. It's either that or try and use some kind of titanium mesh, which is kind of an ordeal because you got to go back in and take it out and all that. So all of those other options I've found to be just kind of full of drawbacks. Let's go to this right here. So from here on out, I'm just going to show cases, patients, just different kinds of deals from removable to fixed. This is Miss Fontenot. This is going to be a problem. We've got a bunch of recession here. She's got decay all over the place. I mean, it's just a train wreck and a half. Got these problems down here, lower front teeth are banging against the uppers. All this stuff going on. And some people right off the bat say, well, just take out all the top teeth. Well, I wanted to hang on a few of these to support her temporaries while the implants are integrating. So we looked at, and this is a case presentation. Okay, Ms. Fontenot, we got endo on both of these teeth. We've got some bone issues up here where this upper molar is. It's, big bad infection around that upper molar. Here's the premolar. And like I said, you can really see some stuff in cross-section that on regular PAs is not all that apparent. Got all this going on in the front. Over here, got this going on over here. So this is what we'll show to patients when we're trying to get them to ascertain what's going on. Here's a full dentition. This is all you got left. All right? And out of all you got left, everything in yellow is a bad thing. It's all infection. And they kind of start to get it, you know. It's like, well, we can bone graft here, 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 root canal, and use these teeth to support the provisionals while everything's healing, okay? And so we have fixed cemented bridge work on the top. And then after this is healed a little bit, then we'll come back and put implants in these areas as well as down here. This is what it's going to look like when it's restored. And that's what we did. So here's our AnyRidge implants on the bottom, tapered screw vent, AnyRidge, tapered screw vent, AnyRidge. Today, I do all AnyRidge. And so here's an after shot of everything in place. All of this is healed. It's been in provisionals a long time. Then we come back and put our implants in and our provisionals. This is after. I'm sorry I don't have a shot of the lip raised up. That's before. That's after. Before and after. So, you know, just a lot of different ways to skin a cat. If I had to go back and do it again today, would I do it the same way? Probably so, but maybe not. You know, every patient's different. Some people, I don't mind wearing a denture. Good, let's just take all the teeth out. You wear a denture while the implants heal, and then we'll move into the fixed phase after.
What was that program you were just showing? Where you showed?
That I stole that from I don't even know who. Somebody had it on their website, some company like Zest or something like that. I'll send you the file. And all I'm doing is I'm using Snagit. Do y'all have Snagit? You know what that is? It's a company called TechSmith, and they have no relation to me. They have a program called Snagit, and I have it on every computer that I own, and everybody in the office uses it all day long. Whatever's on the screen, you can snag, you know, an X-ray or a whole screen or this or that. Whatever's on the screen, you just make a box around it and save as, and you're able to save it as an image, or you can say copy to clipboard and plug it right into PowerPoint. So if I wanted to show cytoplast membrane from the website, all I did was put Snagit, copy, or it imports it right into PowerPoint. So it's just a neat program. It's like $30. I could not live without it. I mean, use it all the time. So all I'm doing is go into Snagit, snag out the whole smile. Then we extract all the teeth, put all the conditions, snag that, and everything just layered on top of each other in PowerPoint. And sometimes I won't see a patient for a year or two. And they'll come back, I'm ready to have my work done. My husband wants to know what's going on. It's like, I don't even know who the hell you are. Yeah. But you happen to have a consultation folder in the file, and so let's go look at that. You know, and then otherwise I can't remember anything. So as a routine, when somebody's in for a new patient exam, somebody needs substantial treatment, we take photographs, CT if we need it, X-rays. I'm not in the room, I swear, for more than 10 or 15 minutes at the most, because I want to sit down when they're not in the room and think. I can't think when they're in the room. What was I talking about? Yeah. Snag it. So you got to have Snag it. You got to have it. It is really, 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 really good. Okay, so this is Never's Fontenot. The case we were just looking at? Okay, let's see. This?
No, the one with the implants.
Let's see. And like I said, you know, just using Snagit and drawing all this stuff in there, copy it, paste, copy, paste. And so when you're going through the PowerPoint, you know, Tammy can just go through this. She can print the whole thing out, you know. What are we looking at?
Well,
Here?
What I'm seeing, you see that? What implant is that?
This?
Yeah.
Tapered screw in.
It's got bone loss around it.
Exactly.
The Megagen don't. The bone grows up to the top of those implants.
I'm not using these anymore. You know, and it's like when I started talking about platform switching, people, oh man, you know, that's a fad and this and that and this and that. Now everybody's kind of into it. This is a case that Malone and I did together. This lady had an upper denture. She's got this fixed bridge work on the bottom, which we wound up sectioning these ponics out and placing implants later. But the main thing was she wanted to get out of a removable prosthesis. So we do her scan, and the problem, and you can see we've got a duplicate of her denture made with 10% barium sulfate and 90% acrylic, so we can take our scan and see where we lie. And so when we start up in the upper right quadrant in the area of number 3, not a lot of bone. Here we are on number 4, a little better. really a lot better, I guess. Number 5, not too good, pretty thin. Number 6, pretty thin. 8, better. 9, better. This is 11, thin again. 12, thin. 13, a little better. And 14, not good. So then we're going to go in and measure all this. So the foresight, like I said, is pretty good. We know that we got 4.8 width, 7.6 height. So we're just going through and measuring all these areas. Get it number 6. It's 2.6 right here, 4.0. I'm thinking about bone spreading, this deal right here. Because the options are go in and try to graft all of that. Then she's wearing a denture. It's kind of a job, big job. And so I'm really thinking about doing a real nice job of bone spreading in all these areas because the cortices are apart. There's cancellous space right here. And so we've got a game plan. And so I decided to do guided surgery. When we do guided surgery, we make the guide to fit on the bone, not to fit on the soft tissue. Because I promise you, if you make one of these and you bolt it in their mouth and you just drill through, there's no way it's going to bisect those thin ridges just right. I mean, it just isn't there. It's accurate, but I don't think it's that accurate. And like I said, I've been burned a couple times, and so has my partner. So I trust it, but I only trust it if this locks onto the jaw. And so we go to the mouth, flap everything, got this locked into place. And what we're going to do is we're going to use a piezo to do the initial osteotomies instead of a drill, just because it gives us more control and it gives us a smaller point of entry. So we're going through the guide with the piezo and looking through the window too. I can see where I am. And as we make each initial penetration, we're going to put a Brasseler taper diamond burr to look at our parallelism and look at our alignment. And so this came out pretty nice. It was planned on the guide so that mesiodistally we have everything where it needs to be. You know, the worst thing for a case like this, particularly with Mike, is if one of the implants is between 10 and 11 or between 9 and 10. I wanted to make sure that we got everything right where it needed to be. So here's the initial penetrations. Then we're going to follow up using these bone spreaders, okay? And so here's the initial BTI bone spreader going in each one of those osteotomies. Just 1, 2, 3, doing them all at once. And then we'll come back and start placing implants at the same time. These are all tapered screw heads, by the way.
Now you made horizontal cut with piezo all the way down the ridge, or did you not just start?
I use a piezo just to do my initial osteotomy instead of a drill, because you have more control. With the drill, it kind of tends to want to go wherever. And this is such a delicate case that I wanted to make sure I didn't do anything to screw it up. And that, you know, it meant slowing down and taking a few deep breaths, but you know, we got this going on at that initial visit, and it really worked out well. You know, I came in and put some stock abutments in, put her in temporaries. Then I sent her back to Mike. He didn't want to use the stock abutments. He made all custom abutments for her. But these are his temporaries. So here she is provisionalized. He kept in provisionals for a good while, make sure the aesthetics was good and phonetics and all that other kind of stuff. And so here she is during the provisional phase. These are the final restorations here. Just a nice, good patient, nice result. Came back and then did individual implants on the bottom so we could get rid of those fixed bridges. And that was pretty much it. So guided surgery, you know, I don't know. I'm on the fence about using it blindly. Any questions? What time are we finishing? 4? 3:30? 4. Okay, 4. Get all those CE hours.
Do you ever use your piezo for ridge splitting?
Yes. Yeah. It's the ticket. It really is. In fact, back when we were doing blade implants, I wish we'd have had a piezo back then, because you could cut a perfect slot and you could put that implant right in there instead of trying to use a hand piece and all that stuff. By the way, my mom still has a blade. It moves, but she can eat with it. So, this is a guy named Scott from Jennings, Louisiana. When we're doing a case presentation, I'll image a patient like this in Photoshop just to show him what I think we can accomplish. This is what he started off with, just real bad dental phobia. That's a poor imaging job. But real bad dental phobia. And he's overclosed posterior. I mean, this is a mess. And a lot of people look at this and just start thinking, that's dentures. This guy's like 32 years old. He's got a good job. He doesn't want to have false teeth, and neither would I. But this is a wreck. So what we did was, in his presentation, identified all the problems, and he's got them all over the place. And so what we're thinking about is just trying to get him back into first molar occlusion. This is his scan. And so at the consult appointment, when Tammy's presenting the case, she'll show him all this stuff. It's a wow factor deal. But with ICAT, we had to order these things. It was like $90 to have this made. With Prexion, you just do it yourself. And, it's pretty fascinating. And the next one we'll show is just to show them where the anticipated implant sites are going to be. So we're thinking about first molar occlusion on the right, first molar occlusion on the left, 3-unit bridges in the front. But once again, using this program, and I gave you that link at the last course. Remember, it's called Dental Flash. This is what you got, Scott. This is all that's left. In fact, I forgot to knock out 10 because 10's in bad shape also. So here's what you got. Here's really all that's left, and 10's history also. And so what we think about is putting implants in these sites, fixed bridge work in the front. That's option A. Here's how it would be restored. 1 here, 2 down there, and then all the way across the top. And then you have option B. And option B is going to be to, take everything out on the top, put 4 implants in, and make some palatless overdenture thing. And he really wanted to keep his teeth. So this is what we wound up with. These are all AnyRidge implants. Just really super result. Looks good in the mouth. Looks good on the x-rays and all that. And this is the day we put the case in. So everything's kind of bloody. This is after he's healed for a week or so. Right side, left side, he's bleaching right now. That's before. This is after. And I just think it's cool that we can even do this nowadays. I mean, I wouldn't have dreamed in 1980 we got out of school that we'd ever be able to do anything like this that would look this good and be able to give patients back their original function again. So real good patient, good guy. I'm glad it all worked out for him. Okay? And next, this is a pre-op Panorex on a patient that has a beer distributorship in New Iberia. I don't know why I remember that, but I just remember that about him. So here we're going through the CT scan. We're looking at the amount of bone width, upper right quadrant, upper right center, left, left. So he's got good bone width and so forth. This is the game plan. It's using Photoshop. Just kind of give him an idea what we're thinking about on the top. And then putting implants here on the bottom. Restoring it like so. So this is the case. 5 implants in the maxillary arch. He didn't want to do the bottom now. He's still in the partial. And these are tapered screw van implants. By the way, this one fell out. This one lost integration after it had been in function for a while. And it's no wonder. I mean, look at the, this is D4 bone. We got a little machine screw in there and this real long, what do you call it? Lever. It'd be a long lever. So we went back and replaced that with an AnyRidge implant down the road. But this is what he was wearing. Reline this with CoSoft. Let these things heal up real good. Comes in one day. We keep a lot of locators in inventory, so we go ahead and put those into place. Then we're going to take his denture. We're going to wallow out the areas above those locators, check it with fit check to make sure it's seating passively. And we have no pink showing through any of these spots, maybe a little bit right there. So we'll keep relieving this until we're sure this is 100% seated. And then once we know that we've got it seated all the way, then we're going to pour this up. This is a polyvinyl siloxane. So we're just going to pour it up in stone. And then we're going to mount this, and we're going to mount this thing on a reline jig, which is another story, another lecture altogether. But in other words, we're going to do the reline in the office so that when we're done, Now we've got good hard cured acrylic all the way around, and then we're going to come back and cure these attachments in. This is his original denture. All we're trying to do is convert his original